Hello everyone. So today we're going to pick up off of cardiovascular, ACS, ischemia, MI, etc. So MI, you have acute coronary syndrome, referred to as ACS. This is the continuum from angina to an MI. Symptoms of ACS are due to an imbalance between myocardial oxygen supply and demand. Women and older adults do not always present with typical symptoms. I've seen a lot of ladies who are having an MI. They complain of pain radiating down both arms. Angina pectoris, this can be a warning sign of an impending MI. So angina is chest pain resulting from myocardial ischemia, and it's caused by inadequate myocardial blood and oxygen supply. Causes can include obstruction, coronary blood flow resulting from atherosclerosis, coronary artery spasm, or conditions increasing myocardial oxygen consumption. So the majority of MI deaths occur with 1 hour of symptom onset. Education, early recognition, and treatment is essential to prevent death. Educating your patients on taking nitroglycerin as well as calling 911. Frequently I have a lot of patients who will come in and say, yes, I have chest pain, it's radiating down my arm, I was diaphoretic. And, I tell them, don't wait, they need to call 911 ASAP. So the relationship between CAD and chronic stable angina and ACS. So you have coronary artery disease, which can lead to chronic stable angina, or acute coronary syndrome. Acute coronary syndrome can be broken down to unstable angina, a non-STEMI or non-segment non-ST segment elevation MI, or ST segment elevation MI. So with stable angina, this is also called exertional angina. And it occurs with activities that involve exertion or emotional stress. This is relieved with rest or nitroglycerin. Often you'll have a patient complain of mowing grass, they're having angina, and a lot of times they'll tell you, well, I had to stop and rest. Or I took my nitroglycerin, then my pain went away. That's stable angina. It usually has a stable pattern of onset, duration, severity, and relieving factors. With unstable angina, this is also called pre-infarction angina, and it occurs with an unpredictable degree of exertion or emotion. And it increases in occurrence, duration, severity over time. Pain may not be relieved with nitroglycerin. So what are some interventions for angina if a patient's in a hospital and you may be the nurse? So the first thing you want to think about is getting a set of vital signs, an O2 sat, applying the patient on 2 liters of oxygen. The patient may already have a PRN order of nitroglycerin, and then of course you would want to get an EKG, call the house doctor. Typically what I would do in the past, if I had a patient who's complaining of chest pain, I would automatically get the vitals, put them on 2 liters of oxygen, get my 12-lead EKG. I'd have somebody out at the desk call the doctor. So when the house doctor comes up to the floor, they have all this material in front of them. Also, you want to make sure the patient has IV access as well. Typically, if the nitroglycerin is not effective, the next thing that you would give is some morphine, and we'll discuss that later. So when ischemia is prolonged and it's not immediately reversible, acute coronary syndrome develops. So ACS encompasses unstable angina, UA, or non-ST segment elevation, non-STEMI, or ST segment elevation MI, which is referred to as STEMI. So you see in the next slide the pathogenesis of atherosclerosis. So there's obviously damage to the endothelium, fatty streaks, and a lipid core formation, fibrous plaque, raised plaques are visible, complicated lesion, then you have the thrombus, and then plaque is complicated by a thrombus deposition. So we've talked about before in the past collateral circulation, and this is when more than one artery supplying a muscle with blood is normally present in coronary arteries, especially in older people. Development of collateral circulation takes time and develops when chronic ischemia occurs to meet the metabolic demands of the body. Therefore, an occlusion of a coronary artery in a younger individual is more likely to be lethal than in an older individual. Symptoms occur when the coronary artery is occluded to the point that inadequate blood supply to the muscle occurs, causing ischemia. Coronary artery narrowing is significant if the lumen diameter of the left main artery is reduced at least 50%, or if any major branch is reduced at least 75%. So with my mother, she had severe coronary artery disease. She was having some chest pain when she was mowing grass. It stopped when she sat down to rest, and so she had to have a heart cath, and one of her arteries, I think it was maybe the RCA, it was occluded 90%, so she had to have triple bypass. I think her other one, she had an occlusion of 75 as well as a 50, and that was, I want to say, like last year around December. So if you turn the next slide, I'm going to have you read through that on your own. So with acute coronary syndrome, the etiology and pathophys. So you have the deterioration of once stable plaque, it ruptures, you have platelet aggregation, and then a thrombus. So it results in partial occlusion of a coronary artery, which is UA or NSTEMI, or total occlusion of coronary artery, which is STEMI. So with myocardial infarction from occlusion of a coronary artery, as you see in the photo, obstruction of the left anterior descending or LAD artery, that results in the anterior wall. Obstruction of the circumflex artery results in posterior wall MI or a lateral wall MI. Obstruction of the right coronary artery results in the inferior wall MI.
Hi.
Okay. Okay.
I put this in my hair.
That's great. Looks wonderful. Okay. I need to get back to what I'm doing. No, you got your phone taken away because you talk back. Now, go please. All right. Sorry about that. Okay, so pathophysiology of an MI. So blood flow to the heart, of course, is compromised. which causes ischemia, therefore angina. And MI anginal symptoms unrelieved by rest or nitroglycerin are lasting for more than 15 minutes. So with the pathophys, I'm not going to read that first bullet point where it says contractility of the heart is disrupted in areas of myocardial necrosis. That's due to ischemia. Infarction does not occur instantly, but it typically evolves over several hours. Most MIs involve the left ventricle, and that's over 2 to 3 months. The necrotic area develops into a scar, and the scar tissue permanently changes the size and the shape of the entire left ventricle. So, stimulation of the sympathetic nervous system as a compensatory response to left ventricle injury or compromise. We talked about the RAS, RAAS. If you recall from pathophys, that is a signaling pathway responsible for regulating the body's blood pressure. So angiotensin 2 not only causes blood vessels to narrow or vasoconstriction, it also simultaneously stimulates the secretion of water-retaining hormone, which is known as vasopressin or ADH, into the pituitary gland, as well as the release of adrenaline, noradrenaline, and aldosterone in the adrenal gland. Whereas adrenaline and noradrenaline enhance vasoconstriction, aldosterone influences the filtration function of the kidneys. So the kidneys retain more sodium and water in the body, and they excrete more potassium. So the vasopressin from the pituitary gland prevents the excretion of water without affecting the electrolytes, sodium and potassium. So the overall volume of blood in the body is increased. So more blood is pumped through the constricted arteries, which increases the pressure exerted on the artery walls and thus the blood pressure. So the release of glycogen stores. The sympathetic hepatic nerves can increase hepatic glucose output. So clinical manifestations of an MI. Patient can be diaphoretic, but not always. Vasoconstriction of the peripheral blood vessels. So you would expect the patient to be clammy or cool to touch. They could be pale or a grayish color. But initially you have an increase in the heart rate and the blood pressure. And then the blood pressure drops secondary to cardiac output. So the patient may have crackles, jugular venous distension. Other complaints of clinical manifestations of an MI would include nausea, vomiting, shortness of breath, dysrhythmias. Maybe they're throwing more PVCs, or maybe they're having runs of VTAC. And often the patient has feelings of fear and anxiety. So the next page that you see here, I'm going to have you guys read over that. Pretty self-explanatory. So location of pain during angina, and you see all these patterns here. A lot of times patients will complain of epigastric pain, maybe some heartburn. The pain is radiating up the chest. So if you give your patient some maybe Mylana And this is an effect of it's still not going away. Don't assume that it's always GI, because it could indeed be cardiac. Now, with women, I've seen, like I mentioned before, a lot of pain that radiates down their arms, as well as mid-sternal pain, but it's to the back. Other clinical manifestations: abnormal heart sounds. So an S3, that can be indicative of heart failure, which is a complication of an MI. It typically occurs during early diastole, and it sounds like Kentucky. It's always considered to be abnormal if it occurs after the age of 35. However, an S3 can be normal finding in children, pregnant women, as well as some athletes. An S4, that can be due to increased resistance due to a stiff left ventricle. It's considered a normal finding in the elderly, and it occurs during late diastole, and it sounds like Tennessee. It's best heard at the apex or the apical area, also known as the mitral valve. So you would listen at the left fifth intercostal space, mid-clavicular line, with the bell of the stethoscope. We talked about nausea and vomiting. The patient can also have a fever due to the inflammatory process caused by cell death. So when we talk about diagnostic studies, obviously you're going to get a detailed health history and physical, 12-lead EKG. There could be changes in the QRS complex. You want to look at the ST segment. Is it elevated? And also look at the T wave, because that can also help to rule out or confirm unstable angina in an MI. So we talk about serum cardiac markers, troponin, CPK, and B series times 3. So one of the most important cardiac markers when you're talking about MI is the troponin. And the troponin 1, it has a very high affinity to myocardial injury, and it rises within 3 hours, and this can stay elevated up to 10 to even 14 days. Total creatinine kinase level, that's a CPK. Often levels rise within 6 hours after the onset of chest pain. Levels can peak within 18 hours after damage and death to the cardiac tissue. A CKMB, that's creatinine kinase, myocardial muscle. An elevation in value, this indicates myocardial damage. A elevation occurs within hours, and it peaks at 18 hours. Levels return to normal in 48 to 72 hours. Myoglobin, this is an oxygen-binding protein. It's found in cardiac and skeletal muscle, and this level rises within 2 hours after cell death, with a rapid decline level after 7 hours. So obviously, with this said, troponin, you're always looking at troponin with an MI. When we talk about heart failure, you're always looking at a BNP, which is the next lecture. So coronary angiography, 90 minutes door to balloon, okay? So this is an invasive non-surgical technique in which one or more arteries are dilated with a balloon catheter. to open the vessel lumen, and that improves arterial blood flow. And they say 90 minutes because studies show patients have a more positive outcome. Other things that can be done, diagnostic studies, an echocardiogram, and that evaluates the heart size, chambers, ejection fraction, and it also looks at the flow gradient across the valves of the heart. So looking at the next page, if you see in your PowerPoints, this tells us hours to days after onset of symptoms. So if you're looking at the myoglobin, that's in the purple. So that's like 1 to 15 hours it stays elevated. Whereas the blue, the CKMB, you see where it peaks anywhere between 15 to 20 and comes down after 30 hours. But when you look at that troponin, that really peaks in about 15 to 20 hours. But look how long that stays elevated. Like I mentioned, up to 14 days. So we're going to talk a little bit about medications. And of course, as you well know, I'm big with pharmacology. So you can expect to see questions on pharmacology on your quiz. So aspirin, you guys are familiar with this. Typically, if someone is having chest pain, you will be directed by the physician to give the patient an aspirin. Things when you think about with aspirin, obviously GI bleed. Beta blockers. So with beta blockers, they slow the heart rate and increase myocardial perfusion while reducing the force of myocardial contraction. This is preferred for treating post-MI and angina, also for high blood pressure as well as arrhythmias. As you well know, this is adjunct treatment if a patient is having thyroid storm because they have an elevated heart rate. So a example of this would be atenolol, remember, OLOL, so that's tenormin. So contraindications to taking these medications. It could cause patients that you want to watch out for: asthma, COPD, chronic bronchitis, emphysema. So why would it be contraindicated? That's because it causes bronchoconstriction. Other things you need to be concerned about with contraindications is bradycardia. Second, third degree heart block. You'll be learning about that. These patients have, especially third degree heart block, very low heart rates, could be in the 20s and 30s. So you wouldn't want to give those folks a beta blocker. Adverse effects, bradycardia. If you recall, it blocks beta 1 receptors in the heart. Bronchospasm, that blocks the beta 2 receptors in the lungs. Causes depression, fatigue. If you remember from diabetes, it blunts the hypoglycemic response. So you need to warn your diabetic patients that they might not feel the typical signs of hypoglycemia, such as tired, irritable, restless, excessive hunger, diaphoretic. You also need to be cautious with this in patients who have heart failure because they can cause congestion. With the ACE converting inhibitors, this is typically given post-MI. ACE inhibitors, it blocks conversion from angiotensin 1 to angiotensin 2, which is a potent vasoconstrictor. And the suffix is PRIL. So an example of the drug would be lisinopril, which is also Zestril. There's a black box warning for ACE inhibitors that they can cause death or injury to the developing fetus during the second and third trimester. Other adverse effects would be angioedema. Patients can develop a dry, hacky cough. And if that happens, typically the healthcare provider just switches them to an ARB. These also cause hyperkalemia, so avoid salt substitutes that contain potassium as well. So, like I mentioned earlier, emergency management, make sure your patient has IV access in the hospital, puts a couple liters of oxygen, give them nitroglycerin, aspirin, and morphine. So with nitroglycerin, you can give that 3 doses, 5 minutes apart. Hold typically if the systolic blood pressure is less than 80. Monitor the patient's vital signs in EKG, get a pulse ox. Emergent PCI, that is percutaneous coronary intervention. And again, that's a non-surgical procedure that uses a catheter to place a stent to open up the coronary arteries in the heart that have been narrowed by plaque buildup. So again, remember the goal, 90 minutes door to balloon. This is typically the treatment of choice if someone has a confirmed MI. Complications could be stent migration or occlusion, bleeding resulting from anticoagulation, coronary artery dissection. So the next page just shows the placement of a coronary artery stent. You see the plaque. So you have the balloon and the balloon is taken out and the stent is there. And that just shows the next photo, the PCI with stent placement. So I'm going to go ahead and stop the video here. I've been having issues uploading videos if they're longer than 30 minutes. So next will be part 2.